Hello friends, today's session is about ovarian hyperstimulation syndrome. It's a green top guideline number 5, the management of ovarian hyperstimulation syndrome. Before we start with the guideline discussion, I would like to mention that initial few slides of our discussion will be pertaining to the importance of this particular topic with respect to the exam, and after that we will be discussing the guideline in detail, and at the end we will have the summary of this particular guideline in 1 or 2 slides. So if you listen to this video carefully, and if you read the guideline immediately after listening to the video and mark the guideline important points in the guideline, or highlight the points, or if you make the notes, that will be very useful for you, especially at the time of final examination for the revision point of view. So we begin with today's topic, that is management of ovarian hyperstimulation syndrome. This topic is important from MRCOG point of view for part 1, part 2 as well as part 3. For part 1, there can be SBA, that is single based answer question from pathophysiology unit of this particular topic, while there may be EMQ scenario or SBA for part 2. For part 3, it can be asked as a structural discussion, or it can be a part of station of subfertility. It may be a role player station of subfertility, where the role player may be a case of PCOS and having anovulation. She is going to require ovulation induction, and we need to discuss about ovulation inducing agents monitoring along with its complication. So the OHSS will be a component of that particular station. We need to discuss about red flag symptoms, when to report to the unit, when to admit the patient, reporting to the HFEA, etc. Not only that, RCOG has got a patient information leaflet on OHSS, so we need to provide information leaflet to the patient, especially when we are performing to the part 3 station. And most important is a safety domain will be covered in today's topic. Not only that, for MS and DNB or FCPS students, it can be a part of full question, or it may be a short note on OHSS. Also, it can be asked in table viva along with ovulation induction drugs and its complications. So what are the learning objectives of today's topic? 1. To identify patients and cycles at high risk of OHSS and apply preventive measures. What are the triggers of OHSS, etiopathogenesis of OHSS, and types of OHSS such as early, late, and the MCQ can be asked on this. Then severity classification, differential diagnosis, outpatient management versus inpatient management. There can be MCQ or EMQ on this particular aspect. Management of OHSS, indications for paracentesis, indications for surgery, these can be also an MCQ, and we should know about regulations for reporting to HFEA, that is Human Fertilization and Fertilization and Embryology Authority. OHSS is the most significant short-term complication associated with ovarian stimulation. It's an iatrogenic and potentially severe complication. Mild OHSS is seen in 1/3 of IVF cycle, that is almost 33% of cases. Again, this can be MCQ. OHSS, which is moderate or severe in nature, is reported in 3.1 to 8% of cases of IVF cycles. Again, this particular figure, 3.1 to 8%, is a moderate to severe OHSS in IVF cycles. This can be asked as a MCQ. Reporting is only required for severe and critical cases of OHSS to HFEA, that is Human Fertilization and Embryology Authority, while mild and moderate cases of OHSS do not require reporting. OHSS is characterized by ovarian enlargement, increased vascular permeability, and fluid shift. So 3 components: ovarian enlargement, increased vascular permeability, and fluid shift. So these three are important. Now, which are the patients which are at increased risk for OHSS? These are young age patients, patients with polycystic ovary, then previous history of OHSS, use of GnRH agonist protocol, high AMH levels, during stimulation if there is high estradiol level or sudden rise in estradiol level or high follicular count and increased number of eggs will suggest that this patient is high risk for development of OHSS. Reduced risk of OHSS is seen with use of GnRH antagonist protocol instead of agonist, costing of overstimulated cycles, and metformin in women with PCOS and dopamine agonist. OHSS is likely to be more severe and prolonged in cycles where the conception occurs. Suppose ovulation induction is done and there is OHSS, and in the same cycle the patient becomes pregnant, she is likely to have severe OHSS as compared to the non-pregnant patient with OHSS. So this is what is the ultrasonographic picture. There will be ovarian enlargement. You will be able to see multiple follicles, and this is the picture which is seen on sonography. There can be a picture MCQ also. So this figure, one should remember how the ovarian hyperstimulation looks on ultrasonography. Now let us come to the what history we should ask from a woman who is suspected to have OHSS. In history, we should ask about time of onset of symptoms relative to the trigger. What was the trigger which was used, that is SCG or GnRH agonist, number of follicles on final monitoring scan, and number of eggs collected, where the embryos replaced and how many eggs were replaced. Polycystic ovary was the PCOS diagnosis in that particular case. Symptoms such as abdominal bloating, abdominal discomfort, pain, any need for analgesia, nausea, vomiting, breathlessness, reduced urine output, leg swelling, vulval swelling, associated comorbidities such as thrombosis we need to look for. And this particular table suggests the classification of severity of OHSS, and it is categorized into 4 stages: mild OHSS, moderate OHSS, severe OHSS, and critical OHSS. Again, here there can be MCQ or EMQ, and in the scenario, the clinical presentation will be given, and we have to classify the patient into mild, moderate, severe, or critical. Here, we can remember this by differentiating mild from moderate and severe from critical. In mild, there will be just abdominal bloating, minimal abdominal pain, and on ultrasonography, ovarian size will be less than 8 centimeter square. While moderate abdominal pain will be seen in moderate OHSS, there will be nausea, vomiting. Vomiting may or may not be present, and ultrasound evidence of ascites is typically seen in moderate OHSS. Ovarian size will be between 8 to 12 centimeter. Severe OHSS, where the clinical evidence of ascites is seen, there will be oliguria. Hematocrit is very important, and it will be more than 0.45. In cases of severe OHSS, there will be electrolyte imbalance, and that is typically hyponatremia along with hyperkalemia. That is sodium level less than 135 millimoles per liter and potassium level more than 5 millimoles per liter. There will be hypoosmolality. Osmolality is less than 282 milliosmoles per kg. There will be hyperproteinemia and ovarian size generally more than 12 centimeter. Critical OHS, here there will be ascites stains, there will be large hydrothorax, hematocrit will be more than 0.55, WBC count will be more than 25,000, patient will have oliguria, anuria, and complications such as thromboembolism and ARDS. Now here in severe and OHS, there is a clinical evidence of ascites, while in moderate OHS, there is ultrasound evidence of ascites. Also, in severe and critical, in the critical category, there is a tense ascites and large hydrothorax, while in severe OHSS, generally there is a clinical ascites, hydrothorax may or may not be present. But The most important other lab parameters such as hemoconcentration, that is hematocrit, more than 0.45 for severe OHS we should remember. Electrolyte imbalance, that is typically hyperkalemia with hyponatremia, and ovarian size between more than 12 centimeter, while in critical OHSs hematocrit value more than 0.55 and WBC count of more than 25,000, along with complications such as thromboembolism and ARDS. So that is how we can remember. Depending upon clinical features, we can classify in this OHSs into the appropriate category. One of the important thing to note, which is mentioned at the end in the table, is ovarian size may not correlate with the severity of OHSs in cases of assisted reproduction because of the effect of follicular aspiration. Women demonstrating any feature of severe critical OHSs should be classified in that category. So you may have a ovarian size which is fitting into the moderate category. However, other features such as electrolyte imbalance, hematocrit values may be corresponding to the severe OHSs, and that patient should be categorized as a severe OHSs, and here ovarian size need not be taken into account. The same we can see here in this particular table. However, in this table, mild, moderate, severe OHSS is given and the classification is same. This table is from TOG and previous table was from GTG. However, if you read the initial lines in the table, OHS may be early onset, that is within 9 days of SCG trigger, or late onset after 9 days from SCG trigger, while GTG mentions early OHSs within 7 days of the trigger and late OHSs after 10 days from 10th day onwards, while TOG mentions early OHSs within 9 days of the SCG trigger and late onset after 9 days from the SCG trigger. So even in MCQ, if you do not have 7 days, then you can select the answer as early OHSs less than 9 days trigger after 9 days from the SCG trigger. So even in MCQ, if you do not have 7 days, then you can select the answer as early OHSs less than 9 days and late OHSs more than 9 days, while rest of the categorization of the mild, moderate, severe and critical OHSs are same in GTG as well as TOC. Now, next is HFEA reporting, Human Fertilization and Embryology Authority. The license center should comply with the Human Fertilization and Embryology Authority regulations in reporting cases of severe and critical OHSs among their patients. So, who should inform? The licensed fertility center. The fertility center where the patient is taking the treatment should report these severe and critical cases, not the mild and moderate cases, to the HFEA. And the units where the patient presents with OHSs, that is any hospital where the patient is presenting in emergency, will inform the cases to the concerned fertility unit where the patient is taking the treatment, while informing to the HFA is a responsibility of the licensed centers. Okay. Then fertility clinics should provide verbal and written information concerning OHSs to all women undergoing fertility treatment, including 24-hour contact telephone number. So whenever the patient is under ovulation induction protocol, we need to provide the information about OHSs, and we should give them the 24-hour contact telephone number where they can access further advice. Women presenting with symptoms which are suggestive of OHSs should be assessed face-to-face by a clinician if there is any doubt about the diagnosis or if the severity is likely to be greater than mild. Face-to-face consultation is must. So there are two types of management, outpatient management and the inpatient management. Which patient can be managed on the outpatient care can be given? This is appropriate for women with mild or moderate OHSs and in selected cases of severe OHSs. Not all cases of severe, but selected cases of severe OHSs can be managed on OPD basis. Outpatient management involve counseling and providing with information regarding fluid intake, output monitoring. In addition, they should be provided with contact details to access the advice. NSAIDs are to be avoided because they cause the renal compromise of the renal function. However, paracetamol can be given and codeine can be used, but otherwise NSAIDs are to be avoided. Women with severe OHSS being managed on OPD basis should receive thromboprophylaxis. The duration of the treatment needs to be individualized, and one need to take into account risk factors and whether or not conception occurs. If the patient becomes pregnant in that cycle, we need to continue this LMWH prophylaxis for first trimester, that is up to 12 weeks. We will continue with the low molecular weight heparin. Next is a paracentesis. So paracentesis of ascitic fluid can be carried out on OPD basis. It can be done abdominally or by transvaginal route, and it should be done under the ultrasound guidance. There is insufficient evidence to support the use of gonadotropin releasing hormone antagonist or dopamine agonist in treating established cases of OHSS. So once the OHSS is established, in that particular case, GnRH antagonist or dopamine agonist, there is insufficient evidence for the use. Women with OHSS being managed on outpatient basis should be reviewed urgently if they develop symptoms or signs of worsening OHSS. In absence of this, review can be every 2 to 3 days is sufficient. Baseline lab investigations needs to be repeated if the severity of the OHS is thought to be worsening, and hematocrit is useful guide to the degree of intravascular volume depletion. We have already seen the hematocrit is very important, and it is one of the important parameter on which the patient needs to be monitored, and we can classify them into severe or critical depending upon the hematocrit value, that is more than 0.45 and more than 0.55 will be, more than 0.55 will be critical, while more than 0.45 will be severe. This table shows how the patient with OHSS needs to be examined and investigated. So general examination should include assessment for dehydration, edema, that is pedal, valval, cycle edema. We need to record the heart rate, respiratory rate, blood pressure, body weight, etc. We need to assess for ascites, palpable mass, peritonism, and measure the abdominal girth, and assess for pleural effusion, pneumonia, pulmonary edema. Investigations: full blood count, hematocrit we have discussed, C-reactive protein, electrolyte, and urea. The typical feature is a hyponatremia along with hyperkalemia. This is also MCQ. Serum osmolality will be reduced, liver function test will be deranged, enzymes will be elevated, albumin will be reduced, coagulation profile will show elevated fibrinogen and reduced antithrombin levels, and SCG to know the outcome of the pregnancy, whether the patient is pregnant or not. And ultrasound will tell us about ovarian size, pelvic and abdominal fluid, etc. And if we are suspecting torsion of the ovary, in that particular case, Doppler is going to be important. And other tests, if they are indicated as per the differential diagnosis, like ABG, D-dimers, ECG, 2D echo, X-ray chest, CTPA, and V/Q, that is ventilation is to perfusion ratio, we need to do. If the patient is admitted, in that particular case, the monitoring will involve daily weight gain, then abdominal girth, daily weight monitoring, abdominal girth, intake and output charting, full blood count, hematocrit, electrolytes, LFTs and RFTs are to be done daily, and as per the indication, the abdominal and pelvic chest ultrasound, ECG, blood gases, and chest X-ray. Analgesia, NSAIDs are to be avoided, and if the pain is severe, we have to look for other causes such as torsion or the ectopic pregnancy. Fluid balance, encourage oral intake to the thirst. Crystalloids are the preferred agents. Colloids for volume expansion can be given, and consider paracentesis and avoid diuretics. Thromboprophylaxis, we have discussed low molecular weight heparin, mobilization, and be aware of atypical presentations with arterial thrombosis and upper body involvement. This is one of the typical feature of OHSS. Third space, fluid collections, paracentesis of tense ascites, drainage of pleural effusion can be performed. and surgery is indicated if there is a coexistent torsion or the ectopic pregnancy. ICU care is required for critical OHSS. So what are the indications for hospitalization? Hospital admission is advisable if the patient is unable to achieve satisfactory pain control or unable to maintain adequate fluid intake due to nausea, shows signs of worsening of OHSS despite outpatient intervention, are unable to attend for regular outpatient follow-up, have critical OHSS, and multidisciplinary assistance should be sought for the care of women with critical OHSS and severe OHSS who have persistent hemoconcentration and dehydration. So severe and critical cases will require multidisciplinary assessment. Clinical monitoring and inpatient management will involve women admitted with OHSS should be assessed at least daily. More frequent assessment is appropriate for women with critical OHSS and those with complications. Analgesia and antiemetics may be used in women with OHSS, and we need to avoid NSAIDs and medicines which are contraindicated in pregnancy. Fluid replacement by oral route guided by the thirst is the most physiological approach to correcting intravascular dehydration. Women with persistent hemoconcentration, despite volume replacement with IV colloids, may need invasive monitoring, and this should be managed with anesthetic input. Diuretics should be avoided as they further cause depletion of intravascular volume, but they may have a role in multidisciplinary setting if oliguria persists despite adequate fluid replacement and drainage of the ascites. So per se, diuretics are to be avoided primarily. However, in multidisciplinary setting, they can be used under certain conditions where there is a persistent oliguria in spite of adequate fluid replacement and drainage of the ascites. Now, what are the indications of paracentesis? Indications will include severe abdominal distension and abdominal pain secondary to ascites, shortness of breath, respiratory compromise secondary to ascites and increased abdominal pressure, and oliguria despite adequate volume replacement and secondary to increased abdominal pressure causing reduced renal perfusion. So severe abdominal distension and abdominal pain, shortness of breath and respiratory compromise, and oliguria in spite of adequate volume replacement are the indications for paracentesis. Paracentesis should be carried out under ultrasound guidance and can be performed abdominally or vaginally, and it is an OPD basis procedure. IV colloid therapy should be considered for women who have large volumes of fluid removed by the paracentesis. Coming to the VTE risk, severe or critical OHSS and those admitted with OHSS should receive low molecular weight heparin prophylaxis. The duration of LMWH prophylaxis should be individualized according to the patient risk factors and outcome of treatment. Women with moderate OHSS, we need to evaluate these patients for predisposing risk factors for thrombosis and prescribe either anti-embolism stockings or LMWH. So, severe and critical cases, LMWH prophylaxis is required, while moderate cases, we need to assess the risk factors in the patient and can give either LMWH or anti-embolism stockings. Suspect VTE in women with OHSS who present with unusual neurological symptoms even if they present several weeks after apparent improvement in the OHSS. So there may be resolution of the primary features of OHSS, but patient may present after a couple of days or weeks with unusual neurological symptoms, and we need to suspect VTE in these particular patients. Coming to the indications for surgery, surgery is only indicated in adnexal torsion, ovarian rupture and ectopic pregnancy, and this should be performed by experienced surgeon. Antenatal risk in OHSS patients. So what is the antenatal risk if the patient becomes pregnant? There is an increased risk of preeclampsia to the extent of 21.2% in patients with OHSS versus 9.2% those who do not have the OHSS. And preterm delivery risk is high, almost 36%, that is almost more than 1/3 cases will have preterm delivery as compared to 10.7% in patients who do not have the OHSS. So among the preeclampsia and preterm delivery complication is more, almost 36% or 1 in 3 cases, and preeclampsia 1 in 5 cases or 21%. Again, this figure we should remember from MCQ point of view. Coming to the prevention strategy, weight optimization for obese and underweight patients prior to the ovulation induction is the first line of prevention. Low dose step up protocol with gonadotropin has lower risk of overstimulation and cycle cancellation than step down protocol. So there is a step up protocol, step down protocol, and step up protocol with gonadotropin has got a lower risk than the step down protocol. Third is a coasting can be done. Now what is coasting? During IVF cycle, where there is a hyper response or excessive response, then in that particular case we can stop the gonadotropin injection, but we continue the pituitary suppression. This will lead to the atresia of the small and intermediate follicles, while larger follicles which are independent of FSH, they will continue to grow. What is the mechanism of action in here is there is a reduction in the granular cells which produce vasoactive mediators such as VEGF, that is vascular endothelial growth factor, and once serum estradiol level is decreased to safe level, that is less than 3000 picogram per ml, final follicular maturation is induced and we proceed with the trigger. If the ovarian response is not settled in 3 days, we need to go for cancellation of the cycle. Other strategies will include use of GnRH agonist for endogenous LH surge in antagonistic cycle, and use of progesterone for luteal phase support, which is equally effective as SCG. So progesterone can be used instead of SCG for luteal support, and in antagonistic cycle for endogenous LH surge use GnRH agonist. So the prevention strategies, one is a choice of treatment, the ovulation induction method. Third, in vitro fertilization regime, go for a GnRH antagonist protocol than the agonist protocol. In coasting, we have already discussed triggering oocyte maturation with GnRH agonist in antagonistic cycle, and other strategies will include single embryo transfer, blastocyst transfer, and elective cryopreservation. Luteal phase support, here we can use progesterone compared to the SCG, and other agents such as metformin, dopamine agonist, and last is a cycle cancellation. These are the prevention strategies for OHSS. One should remember these particular strategies, and if there is a question in the structured discussion, at least 3 to 4 strategies we should be able to mention how to reduce the OHSS. Now coming to the summary or the take home message, the incidence, overall incidence is 1/3 of the all cycles, that is almost around 33%. Moderate to severe OHSS 3 to 8%. Vasoactive substance responsible for OHSS is VEGF. Early OHSS onset is within 7 days of the trigger as per the GTG, and as per the talk up to 9 days, and it is due to the exogenous SCG, and it is less severe as compared to the late OHSS, while late onset OHSS is after 9 days due to the endogenous SCG which is produced from early pregnancy, and late OHSS is more severe than the early OHSS. OHSS is dynamic condition and level of severity may change over time, and hence clinical monitoring and counseling of warning symptoms is must. This particular sentence is very important because it is a spectrum and it is a dynamic condition. So monitoring is very important. Generally, pain in OHSS is mild. It is relieved with paracetamol or codeine. However, there is a severe pain. The differential diagnosis such as ovarian torsion, ectopic needs to be ruled out. VT, preponderance of upper body sites and frequent involvement of the arterial system such as carotid or vertebral artery occlusion can happen, and that can lead to the ischemic stroke. VT risk is to the extent of 0.7 to 10%. Late VT can occur after resolution of the OHSS with visual and neurological symptoms, and low molecular weight heparin prophylaxis for critical and severe cases is required. Moderate cases, we need to assess the patient for risk factors, and either anti-embolic stockings or LMWH needs to be used. If the patient becomes pregnant, in that particular case, the LMWH will be given for whole of the first trimester or up to the 12 weeks. There is an increased risk of preeclampsia we have already discussed, that is 21.2%, and preterm delivery risk of 36%. What are the prevention strategies we discussed? Optimization of the weight, GnRH antagonistic protocol for high risk patients, use of agonist as a trigger in antagonistic cycle, coasting, cycle cancellation, single embryo transfer, use of metformin and dopamine agonist, indications of hospitalization and indications of paracentesis we have discussed, and HFEA regulations for reporting by the treating fertility units for severe and critical cases we have discussed. So these are the take home messages from this particular guideline. Thank you.